Welcome back to Neurology 101 on the ProPA podcast. I'm Dr. G, and today we're kicking off our next major umbrella topic, neurocognitive and structural disorders. First up is a condition you're guaranteed to see on rotations, in exams, and in practice, delirium. Fast in onset, fluctuating, and often reversible, it's the clinical chameleon of inpatient medicine. Did you know that delirium affects up to 50% of hospitalized older adults, especially after surgery or during ICU stays? It's associated with longer hospital stays, increased mortality, and risk of long term cognitive decline. But it's often misdiagnosed as dementia or simply dismissed as confusion. Let's take a little deeper look at the kinder patho. What is delirium? Delirium is an acute disturbance in attention and awareness, typically triggered by underlying medical condition, substance, or medication. It reflects a global cerebral dysfunction, often involving imbalances in neurotransmitters like acetylcholine and dopamine. It's reversible with proper identification and treatment of the underlying cause, but can be life threatening if it's missed. Let's look at the clinical presentation of delirium. The core features, as per the DSM 5, are acute onset and fluctuating course, inattention, and disorganized thinking or altered level of consciousness. Some of the subtypes include hyperactive, which includes agitation, hallucinations, and restlessness, hypoactive, which includes withdrawn, quiet, lethargic, and it's often overlooked, and mixed, which includes elements of both. What are some clues to clue us into the fact that our patient might have delirium? Well, recent hospitalization, infection, polypharmacy, electrolyte disturbance, or substance withdrawal. And we might see it that it's worse at night, called the sundowning effect. All right, so how do we diagnose delirium? Well, it is a clinical diagnosis, and there is no gold standard test. We want to use tools like the Confusion Assessment Method, or CAM, which includes acute onset plus fluctuating course, inattention, disorganized thinking, and altered level of consciousness. Other than that, the workup might include a CBC, a CMP, a urinalysis, chest x ray, EKG, and an ABG. We'll also want to consider getting a head CT if they have focal signs or trauma. Last but not least, we want to review their medications, especially anticholinergics, benzos, and opioids. So, how do we treat delirium? Well, the most important thing is to treat the underlying cause. We want to correct any type of infection, dehydration, or hypoxia, and we want to minimize polypharmacy. Supportive care is also really important. We want to reorient frequently, provide clocks and calendars, promote good sleep hygiene, mobilization and hydration, and reduce sensory deprivation. Use hearing aids or give the patient glasses. We want to avoid benzodiazepines unless withdrawal is suspected, and low dose haloperidol for severe agitation, but we want to monitor for the QTC. All right, now book med versus street med. The book med is going to tell us delirium is acute, reversible, and multifactorial. Street med, your patient's going to come in after a hip fracture repair, and yesterday they were pleasant, and today they're yelling about snakes on the ceiling. You don't reach for the psych consult, you check their medications, get a UA, and catch a UTI, or pain mismanagement before it spirals. Now let's do some quick clinical pearls. Hypoactive delirium is often missed. Look for sudden quietness or withdrawal. Always check meds, electrolytes, and infections. Orientation and sensory aids can prevent and treat. Dementia is a risk factor, but delirium is distinct and acute. CAM is your go to bedside tool. All right, now let's do some practice questions. An 82-year-old hospitalized woman becomes confused and agitated at night. She was oriented yesterday. What is the most likely diagnosis? Is it A, dementia, B, delirium, C, psychosis, or D, stroke? I'll give you just a few seconds. If you said B, delirium, you've been paying attention. Great job. Sudden fluctuating mental status changes in a hospitalized elderly patient equals delirium. Which of the following is the most appropriate first-line management of delirium? A. Risperidone. B. Benzodiazepines. C. Reorientation and treat underlying cause. Or D. Emergent head CT. I'll give you a few seconds. If you said C, reorientation and treat the underlying cause, you are correct. Remember, non-pharmacologic and supportive care is first line. Identify and address the triggers. All right, so some final thoughts. Delirium isn't just confusion, it's a red flag. Recognize it, reverse it, and reduce harm. Remember, hypoactive presentations can be just as dangerous but easier to miss. Next time, we'll shift to the more insidious cousin of delirium, dementia, starting with Alzheimer's disease and moving through the other major subtypes. If this episode helped sharpen your clinical reflexes, share it with a classmate on internal medicine rotation. And as always, this is the Pro PA Podcast, where future pros in medicine are made. Until the next episode.